Good evening, ma'am. Good evening, everyone, all the participants. It's a proud privilege to introduce Dr. Pongki Doctor. She's alumni of Guwahati Medical College, and we are very proud of what she's doing and what she did. Currently, she's working in as a consultant hematologist in Dubai Hospital in the Department of Pathology and Genetics. I'll not take much time, ma'am. Today's topic is lab diagnosis of hemolytic anemia. Ma'am, the session is open to you.
Good evening, everyone. Thank you, Asif, for your kind words. And indeed, we are very proud of you. As we were talking just now, we did the first stem cell transplant in Northeast, and probably your name will go down in history. And thank you, ISHPT, and especially Professor Maitri, for giving me a chance to interact with students on such a large scale. And I'm going to be talking about laboratory diagnosis of hemolytic anemias. So this is the present hospital where I work, Dubai Hospital. And talking about hemolytic anemia. As the term suggests, anemia that occurs because of breakdown of RBCs is hemolytic anemia. But hemolysis and breakdown of red cells is a continuous process. This is the way by which old tired red cells are being replaced daily. So, the normal lifespan of RBCs is average of about 120 days. And the bone marrow, if the lifespan becomes shortened, the bone marrow can increase production of red cells by even 6 to 8 times, provided everything is okay. Nutritional status is good, the marrow is healthy. So, a lifespan shortening of red cells from 122 days to 20 days to as short as 15 to 20 days also may not lead to any anemia. There will be hemolysis, but that would be a compensated hemolytic state. So hemolytic anemia basically is the anemia that occurs because of shortening of lifespan of RBCs beyond the bone marrow's compensatory capabilities. So basically, hemolytic anemia occurs because of red cell lifespan shortening. This is a concept that must be clear. This term should be clear for everyone. Hemolytic anemias can be classified in many ways. There are many, many long classifications. Textbooks have even longer ones. You can take any classification you like. You can classify anemia as acute episodic versus chronic. And of course, acute episodic episodes would occur on a chronic process. Inherited versus acquired. Again, sometimes inherited or congenital defects or problems may be detected at a later age. It may not always be possible to differentiate between them. Or one could differentiate or classify based on defects that are or the problems intrinsic to RBCs versus some causes that are extrinsic to RBCs. For example, mechanical damage to RBCs. There's no defect in the RBC, there's something else happening. Another classification is to classify depending on where the hemolysis is occurring. Is it in the intravascular compartment, or is it extravascular? In fact, I personally prefer intravascular versus extravascular because there are few very specific kind of hemolytic anemias that occur more in the intravascular space. And, having that kind of a classification might be helpful when we are approaching any hemolytic anemia to come to a lab diagnosis. So these are just examples of classification. You can have intravascular, extravascular, immune, non-immune. Some could be congenital or congenital versus acquired. Acquired, you can have immune versus non-immune. In the immune, there could be alloimmune versus autoimmune. Non-immune could be so many, mechanical trauma or acquired disorders like PNH. I will not go into the classification. Please look up an extensive classification. You'll find even causes of snake bites and so many heat stroke, so many situations where you may have hemolytic anemia. I'm going to spend a little bit of time on this Because when we talk about hemolysis, of course, there's the main component of RBCs is the hemoglobin. So the hemoglobin will break up is released because RBC has broken down. So if this occurs into intravascular compartment, you have a lot of free hemoglobin, which will bind with some scavenging molecules like haptoglobin, and which kind of and the hemoglobin haptoglobin complex is pretty large, so it cannot escape into the kidney easily, and thus it saves the kidneys because free hemoglobin can be very toxic. And in any case, the broken down hemoglobin that is free is broken down into heme and globin, and we all know that globin will just be broken into amino acids which will be used. The heme part, the protoporphyrin part of the heme, the iron is reutilized, is converted to bilirubin by heme oxygenase, again, which is again converted to to biliverdin, then bilirubin. This bilirubin gets conjugated in the liver. So when there is excessive hemolysis, there will be surely, this is a rate limiting step. So there will be excess of unconjugated bilirubin. And this is one of the markers of RBC breakdown. And so when we talk about biochemical markers of RBC breakdown, hemoglobin itself, low hemoglobin, when when there's a decrease in hemoglobin by more than 1 gram per week, and if there is no hemorrhage, then surely there is a breakdown, there is hemolysis. Hyperbilirubinemia, especially, definitely the unconjugated one, usually, unless there's a liver issue, it should not go beyond 1 to 4 milligrams per deciliter. RBCs contain certain enzymes like LDH. There are many isoforms, but LDH1 and LDH2 are rich in RBCs. As I said, haptoglobin, which is a scavenger molecule, would be low or absent. If haptoglobin is completely used up, then hemopexin is yet another molecule which can bind, and that can also become low. And glycosylated hemoglobin, which is kind of a constant, which is a very stable marker, would get reduced drastically to values around 3, 3.9. If the hemolysis is very brisk, and if there is intravascular hemolysis, the free and all the hemopexin and albumin, everything is used up, then you can have free hemoglobin in the plasma, and you may have plasma hemoglobinemia, which could lead to hemoglobin urea, and which eventually can lead to hemosiderin-urea. I'll spend a little bit of time to tell you the importance of these. So now hemoglobin urea is after, that means if hemoglobin urea is occurring, the urine is going to appear dark. One has to make sure that there are no intact RBCs. So because even hematuria would give you a similar color. Myoglobin urea is yet another situation where you may have, muscle breakdown, but in myoglobin urea, there wouldn't be any, and both hemoglobin urea and myoglobin urea would have a similar color. And even if we try to read using a spectrophotometer, the same wavelength, it gets excited. So it's the plasma. The plasma, myoglobin will not rise in the plasma. Then hemosiderin-urea, what happens when there is hemoglobin urea? Some of the hemoglobin is going to get reabsorbed by the proximal tubular cells of the kidney, and it'll stay there. The iron there, the cells will break down. The iron there will, get converted to hemosiderin. From time to time, when the cells get sloughed off and they pass on with the urine, if you test the urine for iron, it will give a positive test for iron. So hemosiderin-urea is very important, because when hemolysis is not occurring at some point of time, but it has occurred in the recent past, looking for hemosiderin is a very useful assay. So these are some of the biochemical markers. then one also must learn to differentiate between extravascular hemolysis and intravascular hemolysis. So intravascular hemolysis occurs within the circulation, and it is usually more dramatic, associated with hemoglobinuria and what I spoke about, hemosideриnuria, hemoglobinemia. Free hemoglobin can occur, while extravascular hemolysis occurs in the macrophages of the liver and spleen. Now, spleen is highly sensitive to even small defects. That's why the old aging RBCs, when they acquire small defects, they're unable to repair the membrane, their enzymes are exhausted, then it's the spleen is very sensitive in picking up the macrophages of the spleen. But otherwise, more hemolysis occurs in the liver if there's a lot of damage to the red cells, because liver, there's a lot of blood flow through the liver. But basically, suffice it to say that almost all mononuclear phagocytic system cells are going to be responsible for breakdown of the cells. There are some differences. So as I said, extravascular versus intravascular hemolysis. Extravascular is outside the vascular compartment, so macrophages of liver and spleen. This is, these are all FC receptor mediated kind of uptake of the cells. And there can be some regurgitation into the intravascular compartment, leading to moderate reduction of even haptoglobin. While in the intravascular compartment, usually it is because of some mechanical stress or oxidant stress, and because of plasma hemoglobinemia, haptoglobin is, immediately used up. So it would be very low or absent. Hemoglobinuria or hemosideриnuria would not occur when there is only extravascular hemolysis. Some amount, if there is massive extravascular hemolysis, some amount can spill over into the intravascular compartment. But primarily, these would not occur. Examples of extravascular hemolysis is most of the time autoimmune hemolytic anemias, yes, more so the warm type. You can have some splenomegaly, some history of jaundice, but usually extravascular hemolysis is less dramatic presentation. While when we talk about hemolysis, what we imagine, cola-colored urine, patient has fever, backache, muscle spasms, this is all seen in intravascular hemolysis. So I think it's very useful to be very clear about this, because when we know where hemolysis is occurring, it would also help us to narrow down the possible causes and, come to a diagnosis and to be able to, decide on the investigations and come to a diagnosis. So besides breakdown or markers of RBC breakdown, you are also going to have markers of brisk erythrocytosis, which the marrow would try to do to replace whatever has been lost. And the first thing is reticulocytosis. We all know that reticules are the young RBCs. There is polychromasia. They appear like polychromatic cells because they still have some ribonucleic acid in the peripheral blood. Now, one problem with retic count, we are all used to reticulocyte percentage. I'm sure most of you are now using automated counters with automated retic counts. Otherwise, the manual count involves supravital staining. One has to be very clear that you count enough number of RBCs to express in percentage. Sometimes when the RBC count is low because of breakdown, the reticulocyte percentage may appear a little high. So that needs to be corrected. You have to take into account the patient's hemoglobin or hematocrit and correct the reticulocyte count. A better way, if one has an analyzer, is to get used to absolute reticulocyte counts. Nowadays, in our laboratory, we have started relying on absolute reticulocyte counts, but you need to get used to it. We are not used to those values. Sometimes, however, even with hemolysis, there might be an inadequate reticulocyte response. So if the retic is not high, doesn't mean that there is no hemolysis. There can be nutritional deficiencies like folate. Folate deficiency can occur very quickly if there is increase erythropoiesis. If the bone marrow is not healthy, even a chronic infection, the bone marrow cannot produce properly. And some of the autoimmune hemolytic anemias, antibodies also act against erythroid precursors. In such situations, you may get an inadequate reticulocyte response. Then other features are presence of nucleated red cells. It's the next step after retics. Even nucleated red cells, not normally seen in peripheral blood, may be seen. And if one happens to do a bone marrow, one would see erythroid hyperplasia. And some secondary effects of brisk erythropoiesis could be a megaloblastic change because of folate deficiency. Besides these, one can pick up some specific features and which start actually with the CBC and the blood film morphology. Often the first clue comes from the blood film morphology. One cannot reiterate the importance of looking at the blood film morphology properly and carefully. From the CBC, we know that there is anemia. The indices may suggest that there are, there is a hemoglobinopathy. Presence of spirocytes would suggest that there is a red cell membrane disorder or an immune process where spirocytes are being formed, or any kind of abnormal cells like electrocytes or stomatocytes suggest that there's a red cell membrane disorder. Fragmented RBCs would suggest that there's a red cell fragmentation process on. Hemoglobinopathies can be associated. Sickle cells, if you see it and you're finding hemolysis, the buck stops there. You'll stop all other investigations, but just confirm that there is sickle hemoglobin. Sometimes antibodies, coal antibodies especially, which can cause agglutination of RBCs, can be, in the peripheral blood film, we can see red cell agglutinates. There are some specific changes associated with oxidant damage. And if one actually does a supravital staining, if there's oxidant damage, one can pick up features like Higgs bodies. These are just some examples, but I think our actual investigations will start from the peripheral blood film. So with this, I'm going to exemplify the major types of hemolytic anemias and how we investigate them. So our approach has to be, of course, two-pronged. Both have to go hand in hand. Clinical features, the clinical suspicion has to come. If there is anemia, there will be pallor, weakness. Often, if it's a chronic hemolysis, the patient will say, I've had jaundice 2-3 times, mild jaundice. There may be splenomegaly, hepatomegaly, and brisk, intravascular hemolysis or hemolysis that is occurring now can lead to fever, low-grade fever, dark-colored urine with hemoglobinuria, backache, and many autoimmune hemolytic anemias are associated with lymphomas. So lymphadenopathy, lymphoma may be the presenting feature. Then comes the laboratory tests, which would start with the CBC, definitely logical, and the retic count should never be missed. It's very, very important. And a good peripheral blood film morphology by somebody who is experienced. And along with that, one has to add the basic biochemical parameters like bilirubin, haptoglobin, LDH. I think these are the most commonly performed. Then comes specific tests. Depending on what we have seen and what we are suspecting from these investigations, we'll go for specific tests. Again, in the specific tests too, we'll have some screening tests. Sometimes that may be enough. Sometimes we might need to do confirmatory assays as well. And now let's go and have a look at some cases. And I will try to cover most classes of most types of hemolytic anemias and wind up with a summary. So this was a 22-year-old male who presented to the emergency with breathlessness. As you can see, there's icterus, pallor, low hemoglobin, LDH is high, retics is also slightly high if you correct it for the degree of anemia. But he also says he passed dark-colored urine, which was positive for hemoglobin, no intact RBCs, suggesting hemoglobinuria, because he came, and when we suspect, and all this is enough to tell us that this is hemolysis going on. Coombs test almost reflexively we do, and we also did the G6PD screen, which was negative. And have a look at the peripheral smear. I hope it's clear enough. And we can see some changes in the RBCs. And these blue arrows show us these empty-looking areas in RBCs, also called hemighosts or blister cells, because there is denatured hemoglobin, which is kind of forming a puddle in one corner, leaving these empty spots. There are some RBCs which appear as if a small portion has been bitten off. And again, the history also, there was history. This patient actually had come 10 days earlier with malaria, and at that time he had a normal hemoglobin. So this is nothing but a G6PD deficiency. The G6PD screen was negative. We will discuss this why. So G6PD deficiency is the commonest metabolic red cell disorder. So many people are affected that it's considered almost a polymorphism. And this is the first enzyme in the pentose phosphate pathway. And what G6PD does is actually that it is involved with the synthesis of NADPH, or it reduces NADP to NADPH. This reduced NADPH is necessary to counteract the effects of many oxidant radicals. Oxidant radicals that can be formed because of autooxidation or because of infections or oxidative burst in neutrophils, some drugs, some chemicals. You know, from fava beans also we get something which can cause oxidant damage. All this requires NADPH or reduce NADP. And G6PD enzyme is the most important enzyme for production of NADPH. So its absence can lead to oxidant damage and hemolysis. And there can be various types, more than 230, 40 G6PD variants, genetic changes. And the most severe ones are class 1 and class 2, where the residual G6PD activity is very less. But however, even though class 1 and 2 have similar levels, very low levels, it's the class 1 which is very severe because of differences between the two classes in enzyme kinetics. Though the amount is the same, but the way they behave is different. And in this class 1, person, even without being exposed to some known oxidant, oxidizing substances, can have a chronic non-spirocytic hemolytic anemia. It's a chronic, waxing, waning, low-grade hemolysis will continue. And definitely there will be a neonatal jaundice. And in other cases of G6PD2, neonatal jaundice can be prolonged, can be severe. And so to have a definite diagnosis, one needs to, of course, go for tests, either screening test or a proper G6PD quantitative assay. So what are the indications actually for G6PD testing? Definitely what we had seen, a presentation like that, we have a history, there's a hemoglobinuria, intravascular hemolysis, and we know that this patient had been treated by antimalarials just 10 days ago. We don't need anything else to tell us that it is a G6PD deficiency. So indications are, and sometimes when you are going to, some oxidant drugs you are going to use, it would be prudent actually to test for G6PD. Hemolytic anemia in the newborn, which is non-immune, or there's prolonged or severe neonatal jaundice, or if the red cell morphology is suggestive of oxidant damage. If you have some kind of congenital anemia, and we do not, hemolytic anemia, where few spirocytes may be seen, but the major form is not spirocytes, and it could be what I said, the class 1 type of a G6PD deficiency. So these are all situations where we would test. One can go for the screening tests. All the tests actually test the ability of the hemolysate of the patient to reduce, or the NADPH can give you fluorescence. So it's one screening test is a fluorescence spot test. One can also use a methemoglobin reduction test, what I spoke about. Methemoglobin is formed because of oxidation of ferrous to ferric in the hemoglobin, ferric form. And methemoglobin has a different color. Then we add something else to reduce it. And if the hemolysate has enough G6PD, the brown color will become once again reduced like normal blood color, and within a certain period of time. So these are screening tests. But the G6PD assay also, as we had seen earlier, the G6PD actually converts glucose 6-phosphate to 6-phosphogluconate, gluconolactone, with reduction of NADP to NADPH. So all tests that test for G6PD actually detect the rate of reduction of NADP to NADPH. And NADPH has certain properties. It can maybe decolorize or lead to precipitation of certain dyes, so we can measure the color. It can have fluorescence produced when exposed to certain wavelengths of light, and absorption of light by NADPH at again a specific wavelength. These are some of the ways in which we can detect and quantitate NADPH. Before going any further, I would also like to tell you that situations where we have oxidant damage, if we do a supravital staining, the damaged and denatured hemoglobin can be picked up in the form of Haines bodies. And it's these Haines bodies, when the spleen tries to remove them and takes off a portion of the RBC membrane and RBC, that you get those bite cells. Against some concepts, the G6PD gene is located on chromosome X in the telomeric region. So males who have a deficient G6PD gene or an abnormal gene would be a hemizygous deficient, not heterozygous, or a hemizygous normal. Females can be homozygous normal because they have 2 X chromosomes, can be homozygous deficient, though there would be some production. Complete absence of G6PD is not viable with life. Or females, if one X chromosome has a normal G6PD gene and the other one is abnormal, then the female is what would be considered a heterozygous deficient. Now, the problems is in heterozygous deficient females, you expect the cells to have 50% G6PD activity. But because of the phenomena called lionization or random inactivation of an X chromosome, it's very random. We cannot quantitate, or we cannot say how much of it, how much of the cells have inactivated the X chromosome. So heterozygous females actually have a mosaic of deficient and normal cells. So screening tests may not be reliable for female patients. You might get borderline, but if you give them some oxidizing drugs, they might be hemolysis. So one must go for a quantitative assay. And whenever the screening test is abnormal or borderline, one should do quantitative assay. And I'm sure many of you know that red ticks, or new red cells, which occur because of hemolysis, which appear because of hemolysis, are rich in all red cell enzymes. And thus, when you do a screening test or even a quantitative assay at that point of time, after brisk hemolysis, we might miss a deficiency. And therefore, following a hemolytic episode, one should, and if the G6PD levels are normal, one should repeat it after 6 to 8 weeks, 8 weeks perhaps, to ensure that a G6PD deficiency is not missed. Another, leukocytes also contain G6PD. It's a very common enzyme, but they usually do not interfere with the assay. But if the WBC count is very high because of hemolysis or for some other reason, and there is severe anemia, then there might be some interference. Some G6PD may be contributed from the leukocytes. So while testing, the testing personnel should be aware. I'm sure there are pathologists in the group, and you might need to remove the buffy coat in such situations. There are definite guidelines as to what should be done, and they're all easily available. One should follow them. There are other enzymes, far, far less common. So sometimes when there is evidence of, oxidant damage or even some hemolysis, we should think of, and G6PD on repeat also is normal, we should think of other enzymes. There are a few more. I have just picked up pyruvate kinase deficiency is the commonest enzyme deficiency that is affected in the glycolytic pathway. It's very uncommon otherwise, but common in some, particularly in the Amish people, particularly in Pennsylvania. And all that has come from one particular couple, it seems. And the clinical features can be very variable. Neonatal jaundice can be seen. And this assay is even more troublesome. Leukocytes have to be removed because there are lots of isoenzymes which are not affected by the genetic mutation. And retics and young RBCs will also cause false negative tests. Maybe a genetic test might be easier if there is strong suspicion, and one might consider looking for the genetic mutation. And pyrimidine 5' deficiency is again a very rare enzyme deficiency, but it is the commonest in the nucleotide pathway. How exactly it causes hemolysis is not very clear. And one fun fact, most of the enzyme deficiencies lead to hemolysis, but you all must have heard about adenosine deaminase, the deficiency of which causes, is associated with severe combined immunodeficiency. Strangely, marked excess of adenosine deaminase is associated with mild hemolytic anemia. This is just an interesting fact, perhaps not really, practically not of much use. So is it okay? Can I proceed? Are you all tired already? Are the participants allowed to speak, or? It would be nice to have some interaction. Any questions here at the moment? None. I'll check the chat. No problem. So we move on to yet another class of hemolytic anemia. It's a 55-year-old female who had a 6 months history of, progressive weakness. She's given history of jaundice. This is the peripheral blood film. And unfortunately, I cannot interact, but you can see these dense cells which have no central pallor. These are nothing but spirocytes. You can see the blue large cells. These are the polychromatic cells which represent reticulocytes. So this patient had pallor, had history of jaundice. There was icterus at presentation, just palpable spleen, anemia with some reticulocytosis. Indirect bilirubinemia is there, definitely it is raised, while the WBCs and platelets were normal. In such a situation, the first test we are going to do is, of course, a Coombs test, which was positive. So this was a case of autoimmune hemolytic anemia. What is autoimmune hemolytic anemia? Autoimmune, when hemolysis occurs because of antibodies against erythroid antigens, simply it causes autoimmune. If it is it would cause autoimmune hemolytic anemia. Coombs test is the pivotal test around which a diagnosis, if Coombs is positive, we know that this is at least immune mediated. So Coombs test is a direct agglutination reaction. So the basic principle is that there are some antibodies which are formed against the RBCs, but they cannot cause agglutination because they are not large enough or they are not too many, but they are coating the RBCs. And so we treat these RBCs with an antibody against these antibodies. So Coombs reagent is a special serum from a rabbit or some other animal which has been, immunized against human immunoglobulin. And thus, this serum has antibodies against human immunoglobulins or even complement components. And thus, we add this to the RBCs. These antibodies will link several other antibodies and will help to agglutinate. So the incomplete antibodies, which were coating the RBCs but were not able to agglutinate, will cause agglutination. This is the principle of the direct Coombs test. So the Coombs test is the most important test when we talk about autoimmune hemolytic anemia. I will not go into alloimmune, but I'll just briefly talk about it, but I won't discuss it in details. And so this is the direct Coombs test where we are adding the Coombs reagent. And indirect Coombs test is basically when we are trying to detect antibodies in the patient's serum. We use reagent erythrocytes. And so there's an extra step. And then we add the Coombs test, the Coombs serum later on. So we have a direct Coombs test and an indirect Coombs test. So autoimmune hemolytic anemia, as exemplified by the case that I discussed, is caused by antibodies against RBC surface antigens. And very simply speaking, there are two types, warm type and cold type. What do we mean by warm? RBCs are not warm, or the antibodies are not warm. What it means that the antibodies bind against the RBC surface antigens with highest affinity or strongest at 37 degrees centigrade. Usually warm type of antibodies are IgG, sometimes IgM, and very rarely even IgA. What happens is that usually the IgG can coat the red cells, or sometimes the IgG can cause some amount of complement activation. The complement system. It's a system of catalytic proteins, plasma proteins, which kind of activate each other in a cascade system, rather like the coagulation proteins. So, and if it proceeds till the very end, the whole cascade, if it proceeds, it can cause intravascular hemolysis because the last components of the complement system can form a very strong lytic substance. But even if it's activated partially, then even the complement components, when it coats the RBCs, will act as an opsonin. So thus, the macrophages in the spleen and the liver will pick up these cells and cause extravascular hemolysis. Then the cold reactive antibodies actually bind to temperatures which are much lower than the body temperature. So if they bind at very low temperatures, we are not very bothered because those are physiologically not achievable within the body. And cold agglutinins that can cause red cell agglutination, or cold antibodies that can cause red cell agglutination, are also called cold agglutinins. Now, two important terms here are thermal amplitude and the titer. If you know that this person has antibodies which seem to be of cold type, we need to know the thermal amplitude or the highest temperature at which they can bind and they can cause agglutination. If they can bind only at 4 degrees, we are not bothered. So if they're cold, but they can bind even at 30, 28 degrees, 32 degrees, 35 degrees, we will be worried because those temperatures are attainable in the body at, in the periphery, and they can cause agglutination and features like Raynaud's phenomena, cyanosis, etc. Titer is the strength of the antibody, or if we dilute the serum, the highest dilution at which agglutination occurs at the thermal amplitude is the titer. So if we dilute it n number of times, so 1/9 is the dilution, so n is the titer. So as you can see, the pathogenesis is shown here. usually there is complement-mediated hemolysis, and the complement, as I said, it need not progress. IgG usually cannot activate up to the end. Some IgM can, but even if the RBCs just attracts some complement, that is enough for extravascular for the macrophages to pick them up. The complement just acts as an opsonin. And this is an example of presence of cold agglutinin, where all the RBCs are totally agglutinated. And after incubation at 37 degrees centigrade, the agglutination has reversed slightly. In such a situation, unfortunately, I don't have a CBC report. You'd get a very abnormal CBC. The MCV would be high, MCH, MCHC would be beyond physiological limits. And in such a situation, that should alert you that peripheral smear would have a picture like this. And you cannot release the MCV and MCH results. Only result that, and even the RBC count, because the instrument will read this as one cell. So the MCV will be huge. It will be very dense. And the RBC counts will be very low. So the only thing that can be released from the RBCs is just the hemoglobin, because for hemoglobin to be measured, RBCs would be lyse, so it would not be affected by cold agglutinins. So the CBC finding is very, very peculiar. So again, just to sum up, all autoimmune hemolytic anemias could be either the warm antibody type or the cold type. In the cold type 2, please be clear that there can be two types. The cold, secondary cold agglutinin syndrome. These are terminologies that are used. When it is secondary to, say, an infection, often it's a viral infection, and it is called secondary, and it is called cold agglutinin syndrome. While a primary cold agglutinin disease is usually cold antibodies, which can cause agglutination, and the antibodies are clonal. And usually this is associated with a low-grade lymphoproliferative bone marrow disorder. Often, now it's also understood that often this low-grade lymphoproliferative disorder may not really be, classifiable as a marginal zone. We all know that all lymphoproliferative disorders have a tendency to form antibodies, but some of them will not have, you will not be able to come to a specific diagnosis, but they form cold, so they are called cold agglutinin disease. So when you have cold antibodies, one should definitely think of going right up to the bone marrow and even flow cytometry. You can have some mixed type where you have some warm antibodies and cold antibodies. And a very peculiar type of autoimmune hemolytic anemia is a paroxysmal cold hemoglobinuria. It's not very common nowadays. It used to be seen with tertiary syphilis, which is no longer very common, but still seen from time to time post some viral infections in children. This is very peculiar in the sense that this is an IgG antibody, but it binds to our red cells at a very low temperature and binds complement to. The complement, for it to be active, needs higher temperature. So it will bind at a low temperature, and at a higher temperature will cause lysis. And this is absolutely intravascular hemolysis. If you see, all types of these are predominantly extravascular hemolysis, but this paroxysmal cold hemoglobinuria, because the complement pathway is completely activated right up to the membrane lysis factors that are formed. And therefore, this is a very peculiar kind of a very interesting kind of a hemolytic anemia. And as I said, what they usually do is the Donat-Landsteiner test, which picks up the antibodies associated with paroxysmal cold hemoglobinuria, where you need to incubate the patient's serum with some donor RBCs, because the patient's serum has those specific antibodies, and they need to be incubated first at a very cold temperature, and then at a slightly higher temperature. Surely you'll see some hemolysis if the particular antibody is present. If you add fresh serum, which is a source of complement, this can become even more, brisk. More hemolysis can be seen, and in parallel, one should run controls where maybe one tube would be kept only in cold, not at 37. One tube would be kept only at 37, not in cold, which proves that for hemolysis to occur, first the donor RBCs, or these are the reagent RBCs exposed to the patient's serum, first must be kept at cold. That's where the binding will occur, while the hemolysis will occur only when the complement can act at a higher temperature. So this is the donor Landsteiner test. It's also called a biphasic antibody. So again, summarizing it, if you have hemolysis and you are suspecting autoimmune hemolysis, you would go for a Coombs test. Now, important is Coombs test. The first Coombs sera that we would use is a polyspecific. It would react against immunoglobulins as well as against complement. Only it's kind of a screening test. If it is positive, one can do a Coombs test with a monospecific antisera. Here, the antibody will be specific and will be able to differentiate between IgG, IgM, or complement component. So usually the warm type has only IgG. Sometimes you can find some complement, some part of complement. But if you have complement, you should definitely look for cold antibodies. How? We do all these Coombs tests at 37 degrees centigrade. In such a situation where we want to look for cold antibodies, we should do at room temperature, which is 18 to 24 degrees. And if we find cold antibodies, we should also do serial dilution to know about the titer. Because if the titer is very low, it may be just very non-specific. And one important thing to consider is that there can be Coombs negative autoimmune hemolytic anemia. And this can occur because if the antibody may be weak, and in spite of our best efforts, we may not be able to pick it up in a routine laboratory. And you might need to send for very sensitive assays like a flow cytometry to a referral center if necessary. Sometimes IgA, most of the time, the polyspecific antisera and even the monospecific antisera, IgA is not available. So if it's IgA, one rare type, you'll not pick up. And sometimes you might try to elevate out the antibody from the cells, concentrate it, and we might pick it up. And a false positive Coombs test is also possible with the use of daratumumab, IVIG therapy, some paraproteinemias, hypergammaglobulinemia. But if there's no hemolysis, there's no problem, just a Coombs test with nothing, we ignore. We are not going to do anything about it. So this is how we will follow up a case suspected to have autoimmune hemolytic anemia. One thing one should be clear is that usually the cold antibodies, you will find only complement. Don't expect to find IgM. If you find complement, you should consider cold, and IgG is usually warm. Then similar picture, but in a very different clinical scenario. A 12-year-old male has, similar spirocytes and polychromatic cells, and has been admitted with abdominal pain. And basically, he had multiple gallstones. 12-year-old boy, multiple gallstones, likely to be pigment stones because of breakdown of him, and some splenomegaly. Retics are raised. And by reflex, we would do a Coombs test. Coombs is negative, and he had a positive family history. So this is a very prototypical case of hereditary spherocytosis, which is an RBC membrane disorder, and the cells acquire a spheroidal shape or appearance, and many times, and there are often 75 to 80% cases are autosomal dominant. So there will be some positive family history. So if we have positive family history, we have a picture like this, that's all. We may not go any further. We need not go any further. we may be just happy at this point of time. Something very similar is hereditary elliptocytosis. Again, you can see sometimes the elliptocytes can be less than what you are seeing. It can vary from 10 to 100%, but definition says that you should have at least 25%, where you may not even do anything further. And if you have these clinical features, you know that you are dealing with a hereditary elliptocytosis. And a bad brother of hereditary elliptocytosis is hereditary pyropoikilocytosis, which is associated with microcytosis. Again, this is a red cell membrane disorder where you have far more poikilocytosis than what you saw in the previous smears. And this case was some reason the child was not very small. It was a 10-year-old child and was not picked up earlier. But it was only after the blood film that they went back and saw that, yes, the child had splenomegaly and there was a positive family history. So these are all red cell membrane disorders. We need to have some idea of the red cell membrane structure before we go any further. Don't worry, I'm not going to talk about all these proteins and molecules, even I don't know. But basically what we need to understand is that a red cell membrane is a lipid bilayer membrane, the cell membrane, which has, and just below that is a cytoskeletal network, cytoskeletal of some proteins. And there are some proteins, again, which are called linker proteins, which are anchoring this lipid bilayer and this cytoskeleton together. So usually the vertical interactions are between spectrin and actin interactions. And if there is a problem here, they usually cause hereditary spherocytosis. While if there is a problem in interaction in the horizontal linkages, usually you get disorders like hereditary elliptocytosis, and a very severe form is hereditary pyropoikilocytosis. Besides this, there are certain channels which take care of the intracellular sodium and potassium. RBCs are very rich in potassium, and potassium content is much higher than outside the cell. And to maintain that, the potassium would tend to diffuse out. Anything from higher concentration will diffuse to low concentration. So there are some pumps which need energy and which pump in the potassium to maintain the levels. So if there are any proteins, and if the genes for these proteins are defective, there can be defect in these pumps, and we can have disorders like hereditary stomatocytosis, where you can have a dehydrated form and as well as an overhydrated form. Most of the time, when we have something like this and patient is okay so far, we are not bothered. Sometimes you might need to take a decision for splenectomy if the anemia is very severe or the person has an ulcer that is not healing and we want to, take out the spleen. Then the hereditary stomatocytosis, both dehydrated and overhydrated forms, splenectomy is an absolute no-no because they are often associated post-spleen even more with thromboembolic phenomena. So in some situations, we might need to investigate further. One needs to know more. And therefore, one has to have some basic knowledge of all the proteins. Now, why the cells take a spheroidal shape? Actually, all these disorders, because of the changes in the RBC membrane, the RBCs become less deformable. RBC in its span of 100 to 120 days has to traverse through many areas, especially the splenic, within the spleen. It has to, it is subjected to a lot of stresses and a lot of difficult situations. So it has to be elastic, has to be deformable. But because of loss of deformability, it will spend more time, has more difficulty in traversing through some situations, which leads to loss of surface area and spherocyte will be formed, which will be even more rigid, and there's a tendency for splenic sequestration and breakdown. Spherocyte is formed because of loss of membrane, surface membrane, because spheroidal shape is the shape that can accommodate maximum volume for the least surface area. So whenever there's membrane loss, there will be some spherocyte formation. So we all have heard and we know about the osmotic fragility test and what is its current role now. Now, in osmotic fragility, it's nothing but red cells are exposed to hypotonic saline solutions of varying strengths. Hypotonic means we reduce the strength of the saline solution and we expose the red cells. We take whole series of tubes, add the same amount of red cells to each tube, and we look for hemolysis. Because normal RBCs, they have a little bit of extra membrane. So once they're exposed to hypotonic saline, anything that is hypotonic will mean that through osmosis, water is going to enter the RBCs. But if spherocytes are present, means there's shortage of cell membrane. So the cells will just burst. They cannot expand. They cannot take in any more water. This is the principle of osmotic fragility testing. But what's the point of doing this? Whenever spherocytes are present, they can be seen even in autoimmune hemolytic anemia. In autoimmune hemolytic anemia, why do spherocytes form? Because on the surface, there is antibody. The spleen tries to remove the antibody. With each passage of the RBC through the spleen, there will be some loss of cell membrane leading to formation of spherocytes. So though the mechanism, the final mechanism is same, but the etiology is totally different, but spherocytes are present, and it will also have the same osmotic fragility will be increased. So osmotic fragility only confirms what you have already seen. Sometimes if you're suspecting, not sure of spherocytes, an incubated osmotic fragility where the blood is kept overnight can, be helpful. But this is a tedious test. And one very important step is to ensure that in each tube, the same amount of blood is added. If we add a little extra blood in one tube, then you'll falsely say that there's more hemolysis in that tube. That's the most important step. And one should avoid the EDT and other salts because we don't want to add to the salt load in this tubes. Then finally we read the color. We read the color using a photo colorimeter or some kind of spectrophotometer, and the tube which has only distilled water will have 100%. We assume that hemolysis is 100%, while the normal saline tube has 0 hemolysis. So from that we can calculate the amount of hemolysis, plot it against the strength, and you can see that in spherocytosis, the lysis will start much earlier. At much higher strengths of saline, lysis will start. While situations where there is no hemoglobin in the cell where there's a lot of excess RBCs, excess RBC membrane, the osmotic fragility will be decreased, as is commonly seen in thalassemia major. In fact, Nestorf test, which is a screening test for thalassemia trait, is based on this principle. But as we've seen, it's extremely tedious. You can spend the whole day there doing this and doesn't add, it's not specific. We have fortunately some better tests. One is the EMA or eosin 5' malimide binding test, which band 3 protein, if you go back, you'll see that band 3 is important structure in this vertical linkage. So anywhere where there's band 3 deficiency will be positive for the EMA binding test, because band 3 protein binds to the EMA and in hereditary, and this binding will elicit, that amount of binding will elicit fluorescence. So in hereditary spherocytosis, there would be a decrease in the mean fluorescence intensity. This is a flow cytometric based test. And there's enough evidence to show that even, hereditary spherocytosis post-transfusion also, this is quite sensitive to pick up the abnormal cells. So this is still considered a screening test because there are other situations where you can get a low mean fluorescence intensity with EMA. And this represents the hereditary spherocytosis. But what has the least EMA binding is hereditary pyropoikilocytosis. And there's yet another test called ectocytometry, which exposes the RBCs to various kinds of stresses and strains, and various measurements are made on their change. And this tells us quite a lot about the ability to undergo stress, ability to expand, ability to elongate. And so a combination of these tests, these are still considered, can help us to differentiate. In routinely, most of the time we do not require, but these are in special centers. And when it's very vital that we need to know exactly what is happening. For example, the EMA binding test. In hereditary spherocytosis, the EMA binding test would have reduced fluorescence. But you also get reduced fluorescence in another type, congenital dyserythropoietic anemia type 2. But if you use a combination of various tests, it is possible to differentiate between all types of even dehydrated hereditary stomatocytosis, which is a defect of the pump of the potassium pump, or the overhydrated hereditary stomatocytosis. Fluorescence may be normal or high, while the EMA binding will be low in hereditary spherocytosis. So in such situations, it might be very useful. Please don't get scared. I'm not going to go into this. This is just to let you know that now we have a whole long list of genes which we know properly. So when there's little difficulty in coming to a diagnosis, and especially now we have NGS, if somebody can look for multiple genes at the same time, and if we know about the genes, it's possible to go straight for a genetic testing. Otherwise, all these membrane disorders, these are considered the first line investigations: family history with the transmission pattern, peripheral blood smear showing spherocytosis, and looking at the MCV, MCH in hereditary spherocytosis. MCH would be elevated, and you might come to a diagnosis and you may not need to do anything else. Osmotic fragility, or even better, is the EMA binding test, which is a flow cytometry test. Flow cytometry may not be there everywhere, but the test per se is very simple. Or ectocytometry in specialized centers could be considered the second line. And perhaps the third line is, SDH page or electrophoresis of the membrane proteins, which will differentiate and will show absence of particular proteins. And one can go for direct sequencing of the causative genes. One can use an NGS panel. NGS basically looks into many genes at the same time. So one cannot go for one by one. So when you can take a huge panel, it would be useful in some such situations. Then we move on to yet another type of hemolytic anemia. Again, these are all real life cases. This was a 50-year-old male who actually underwent a cardiac angioplasty, and he was given a drug-eluting stent. 2 weeks later, he came with petechiae, history of fever, and some confusion. And he landed up in emergency, the same hospital. So the routine investigation showed that his hemoglobin was slightly low, and WBCs were on the higher side of normal, but the platelets were definitely very low. And because he had petechiae, PT-APTT was done, which was quite normal. But here, before doing anything else, look at the peripheral blood film. We are seeing what are these. These are nothing but fragmented red cells, and these are polychromatic cells representing that there is some hemolysis happening. So this was a classical case of thrombotic thrombocytopenic purpura. And this happened because this patient was given clopidogrel. Clopidogrel is a known offender, and such patients need to be put on plasmapheresis, plasma exchange. Otherwise, the mortality can be pretty high. But before making a diagnosis of, or saying that there are fragmented cells, which are called schistocytes, one has to know what exactly is a schistocyte. Just a slightly misshapen RBC, which may have a pointed N, doesn't make it a schistocyte. There are definite guidelines that fragmented cells comparatively will always be smaller than an intact red cell, can have various shapes and sizes, but they would lack central pallor. And because of the breakdown, some microspirocytes are also formed. So when we are actually counting them, we can include the microspirocytes only when you have the other well-defined schistocytes. So if you are saying schistocytes, and along with them, if we have microspirocytes, we can include them in the schistocyte count. And also to say that this is fragmentation is the main issue, then schistocyte should be the most prominent abnormality in the peripheral blood flow, because some amount of fragmentation can be seen in so many situations. To be specific, to say that this is a microangiopathic hemolysis, one has to be aware that this is the main abnormality on the peripheral blood. So we see fragmented cells whenever there is a mechanical trauma or there is some kind of angiopathy. So the cells are traumatized when they're passing through the blood vessels. Even if you have malignant hypertension, this can occur. If there is a turbulence because of an abnormal valve or a mechanical valve, this trauma, this can happen. But in those situations, we are not that worried. But if we have what is known as thrombotic thrombocytopenic purpura because of a deficiency of adampius 13, which takes care of the ultra, with a very large forms of von Willebrand antigen. But if in its absence, those large forms will automatically form tiny clots all over, thrombi all over, which causes a lot of tissue damage. And the RBCs, because of this thrombi, RBCs also fragment and the platelets are consumed. This is an entirely different picture and which is a very serious situation. And this needs to be differentiated. Often the person will have renal failure. There are certain criteria. I'm not going to talk about them, but LDH will be very, very high because LDH would be high wherever this hemolysis. But in TTP, because of extensive tissue damage, LDH is also released. The source of LDH is manifold. So the LDH is a very important marker to follow. So when you have a clinical suspicion or even some automated cell counters can give you a flag for a fragmented red cell, one should look for fragmented red cells. If they're there, one should also know that, a very occasional rare one in the absence of any other feature, one shouldn't get worried. One shouldn't get worried about over every blood film. So in premature small babies, one should have, more than 1%, more than 5%, because in small babies, you can have few 1 to 2% fragmented cells anyway. For adults, at least 1%. And so therefore one has to, the number also has to be significant. And then there are so many other situations which can, even severe vitamin B12 deficiency would be associated with some amount of fragmentation. But TTP needs to be different, needs to be separated out because the treatment is very specific. And if we do not treat urgently, the mortality can be as high as 90%. Then I would like to, I'm coming to the end of my presentation, a very peculiar kind of a hemolytic anemia. Again, this was a real life case many, many years ago. An 18-year-old male had epistaxis, gum bleeds, pancytopenia, and with a low retic count, and the bone marrow showed markedly hypocellular. bone marrow, and he was diagnosed as a case of aplastic anemia. He was admitted in the hospital for aplastic anemia therapy. Strangely, it took some time to arrange ATG, arrange money. In the hospital, suddenly he said that I have passed dark colored urine. And so the urine was tested, it was positive for hemoglobin. Subsequently, his LDH also rose to more than 1,000. So here we have a case, a young male who showed features of bone marrow failure, aplastic anemia, and also had intravascular hemolysis. So this prompted us to investigate him further, and we made a diagnosis of what is known as paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria is a very peculiar disorder. Hemolysis occurs because of an intrinsic defect in the RBCs, but it's an acquired defect. It is an acquired clonal stem cell defect. There is a mutation that occurs in a gene called PIGA gene, which leads to the intrinsic defect of RBCs and other hematopoietic cells. Basically, this gene codes for a glycosyl transferase, which generates a protein which serves, or a GPI protein, which serves as actually an anchor protein for many other proteins. So when the anchor is absent, there are more than 20 proteins which needs this anchor protein. And if that is not there, many proteins are absent in blood cells, RBCs, WBCs, platelets, and lymphocytes. So classically, this is characterized by presence of intravascular hemolysis, can be associated with bone marrow failure. And again, peculiarly, these patients also have thrombosis at very unusual sites. Now, this hemolysis occurs because two proteins called CD55 and CD59 present on RBCs actually keep complement activity in check, but they are absent, and so complement activity can, proceed unabated, and which leads to the intravascular hemolysis. Again, no patient will have complete absence or of this protein. Usually, it's a mixture of cells. Some cells have or very severe deficiency of this GPI anchor. Some will have some. So there's always a mosaicism of cells, and also the presentation can be very variable unless you have a high index of suspicion. Sometimes you may not think of. There may be slight cytopenia because of intravascular hemolysis. Iron is lost with the hemolysis. There can be refractory iron deficiency. Patient may have thrombosis. And of course, now awareness is much more, or patient can present it about Chiari. So any abnormal thrombosis at unusual sites, one should think of PNH. So the diagnosis, you would get features of intravascular hemolysis. And if it is not very obvious, it's here that urine hemosiderin would be helpful, which would indicate that hemolysis had occurred from in the past. And traditionally, Ham's test and sucrose lysis tests were done. You need a series of tubes. Somewhere you put complement, somewhere you don't. But now I think the confirmatory test, if you have a high index of suspicion, and if we go for the flow cytometry test, it has become relatively easy. And so flow cytometry tries to determine or tries to demonstrate absence of GPI anchored proteins on RBCs, neutrophils, or monocytes, not lymphocytes, because lymphocytes have a very long, lifespan. And then, lymphocyte, if the disease is of recent onset, we might miss them. So the basic principle is that, flow cytometry is basically based on detection of antigens using antibodies against specific antigens expressed by certain cells. So the neutrophils, the whole idea is to use two antibodies which will pick up the neutrophils, and then to look for specific GPI anchored proteins. And recently, again, not very recent, couple of years ago, a bacterial toxin called aerolysin, which is which is modified so that it doesn't cause lysis of the cells, has been found that it also attaches to the GPI anchor. So this bacterial toxin, which is linked to a fluorescent label, can also be very successfully used for flow cytometry of PNH. And this is just an example of from a guideline given as to how to write out a report. So basically in the RBCs, we look for CD55 and CD59. Here, I think only CD59, because CD59 is, as I said, is something that controls the complement activity. In its absence, hemolysis is caused. But why the thrombosis occurs or the other bone marrow failure occurs, how it's connected to the GPI anchor, we still do not know. And in the monocytes, we can show that there is absence of binding of flare because GPI is not there. Our CD14, which is a monocyte-specific antigen, is also a GPI anchored protein. In granulocytes, you can again use flare or CD24, which is a GPI anchored protein. Another recent antigen is CD157, and they have all been used in different combinations to make a diagnosis of PNH. So I'm coming to the end of my talk. So I think I'll just wind up. Of course, I have not covered hemoglobinopathies at all, but they can also, there is ineffective erythropoiesis as well as some hemolysis, especially in sickle cell, you definitely get hemolysis. Then I have not spoken about transfusion reactions or alloimmune hemolytic anemia in the newborn. And it's not possible to cover everything. But if you have the concept of warm and cold type of antibodies, those will be easy. So laboratory diagnosis of hemolytic anemia will start with the clinical suspicion, establishing hemolysis. Then we would go to determine the specific cause of hemolysis. And you might need to confirm by specific tests, like an EMA binding is also actually a screening test, but it's pretty sensitive. There are some situations where we might think that, hemolysis is occurring, which is very similar to a hemolytic anemia picture. That is, where you may have anemia and reticulocytosis, if there's hemorrhage, or if anemia due to vitamin B12 or folate deficiency is recovering because of treatment. Very quickly, there'll be a lot of reticulocytosis. Even NRBCs might come out, or even a recovering bone marrow. And it's recovering throughout a lot of polychromatic cells, but anemia is still there. Anemia plus jaundice can be seen wherever you have ineffective erythropoiesis, like megaloblastic anemia. There'll be some jaundice and anemia. You might see nucleated red cell or bleeding into a large bleed into a body cavity. Over time, because of breakdown of heme, there will be those breakdown products causing jaundice, and the bleeding has caused anemia. Sometimes unconjugated bilirubinemia or neonatal bilirubinemia, hyperbilirubinemia also would make us think of a hemolytic anemia. And if the bone marrow is invaded, leading to myelofibrosis or metastatic disease, you may have nucleated red cells, a lot of polychromasia, some anemia. And though there might be left shift on in the neutrophils, you think it's a reaction to the hemolysis. And as I said, myoglobinuria, because of the dark colored urine, is also a differential diagnosis. First thing is that this talk is over. I'm not going to talk about any more lab tests. So I think that should make you happy. And again, just to wind up what I said, there are many of these charts, again, available all over. I've just picked up one to make my job easier. And Dr. Prashant Sharma et al. From PGI Chandigarh have published a beautiful paper have written a review on hemolytic anemias, and they've also given a flow chart. This is slightly different. So this is just to tell you that initial workup will be to establish hemolysis. Look for lactate. Easiest is LDH, haptoglobin, unconjugated bilirubin. Retics sometimes can be low. And if it is consistent with if it is not consistent with hemolysis, of course, you'll think of other causes. Then the next step is to look at the peripheral blood film. If you find bite cells, if you do Haynes body test, you will think of oxidative damage. Again, I did not talk about unstable hemoglobins because I didn't speak about hemoglobinopathies at all. There are some hemoglobins which are abnormal, which are unstable, and they quickly undergo, because of some amino acid change, quickly undergo oxidant damage. And again, they're associated with dense body formations. Then if you find specific cells like sickle cells, you already have the diagnosis. If you see fragmented cells, you would look for a cause. Is there trauma? Because trauma like excessive even walking, excessive running, or some kind of a turbulence in the vascular system can also lead to fragmentation. If not, we should think of a microangiopathic hemolytic anemia, and we are most worried about this ETP. Again, we need to look at the LDH, look at the clinical picture. This diagnosis must be made very quickly. You should have a high index of suspicion. There could be other causes of, schistocytes. Then, if there are spirocytes, it could be hereditary spirocytosis, where you will think about osmotic fragility and EMA binding test and other membrane disorders. Elliptocytosis, if you see elliptocytes, you know you're dealing with hereditary elliptocytosis. Sometimes, as I said, you may get fewer elliptocytes in the peripheral blood, but still it might be a hereditary elliptocytosis, so you need to investigate. And if it is direct or the Coombs test is positive, it could be any of these autoimmune hemolytic anemias. You should take history of blood transfusion, because if there has been blood transfusion in the recent past, it could be an alloimmune reaction, or it could be a drug-induced autoimmune hemolytic anemia, drug-induced hemolytic anemia, which I didn't talk about. So that brings me to the end of my talk, and I'm open to any questions that you might have.
Thank you, ma'am. Thank you so much, ma'am. You have just covered an entire big chapter in an hour. We do have some questions in the chat box.
Okay, let me see.
Yes, ma'am. So Dr. T.M.S. Rao, he is asking that in HS patients on transfusion support can develop secondary immune hemolytic anemia. How would you differentiate them? Obviously, Coombs positive in a known HS would give us the clue. Would osmotic gradient ectocytometry more useful?
Oh, is the question written here?
Yes, ma'am. It is in the chat box.
I really don't know. One-time blood transfusion should not cause a lifetime, but at least we have seen that positivity for a long time. Whether it can last lifelong, I don't know. You would know more probably.
Ma'am, I just wanted to ask you that, ma'am, regarding allo antibodies,
yes.
How long, ma'am, do you think it will persist? I mean, after the last transfusion?
Up to the, actually it's difficult. One is simple, straightforward, is that up to the lifespan of the RBCs, 3 months. But the whole process, once it is, started, alloimmunization, antibodies can continue to form in many ways. So, sorry, I cannot answer this question.
No, we have a problem.
I'm not a transfusion expert either.
So, that's sometimes we have a problem in say thalassemia patient, thalassemia intermediate patients wanted to undergo splenectomy because of persistent anemia. But then when we work up and we find that the patient's the Coombs test is O positive, and that turns out to be allo antibodies. So there is no way that we can carry out elective splenectomy at low hemoglobin and also transfuse blood at that point of time.
Yes, but actually, that's a whole long different chapter altogether, because you also need to know the antibody specificity, and that's a totally different line of investigation altogether. So I really haven't, my talk hasn't covered that at all.
Okay. So, ma'am, there is another question from Dr. TMS Rao. He's asking that in our audit, we found use of 24 gene needles for blood draws associated with spurious histiocytosis. I mean, probably he's asking about microangiopathic hemolytic anemias using small needles.
Such a big, it's too big by any standard. We don't see. Okay. It's 24% is really a huge number. But usually you will not find 1%. 1% means in the one field, we see around 200, maximum 300 RBCs. So you need to see 2-3 cells per field. So one occasional one, that's why we have a cutoff. And the role of non-compatible PRBC transfusion, we try to find compatibility. And if we don't, we give the least incompatible one anyway, when it's life-saving. But nowadays, some suggestions are there that instead of using least incompatible, we should use the term most compatible and take the usual care. There was one question about that. Yeah.
There is one question from my side.
Yeah.
So a patient of autoimmune hemolytic anemia with completely incompatible PRBC. I mean, severe anemia with hemodynamic compromise, but the patient, we cannot transfuse blood because it's completely incompatible in our shelf. So in that scenario, if we give IVIG,
yeah,
it will still be incompatible. But is it possible that we can transfuse an incompatible blood and hope that it will not be hemolyzed?
Usually what we do is we test for as many as possible, and we test for as many as possible. And wherever the reaction is the minimum, the strength of reaction is minimum, and whichever is the best solution, that's the one we will authorize. And that also has to be accepted by the clinician. He has to be fully aware that this is the situation in which we are releasing that particular unit. And that's what we follow.
Okay. Ma'am, another question is that regarding the thermal amplitude of autoantibodies. So we have patients from Highlands who have autoimmune hemolytic anemia, and in such a scenario, it becomes important to us to know the thermal amplitude. Yes. So we'll ask whether they have to go back home or not. Now, when we test for thermal amplitude, the container of the, I mean the vacutainer of the blood, is it okay that we keep it in the fridge at 4 degrees Celsius and then test it in the tube agglutination? And if it is not, and we examine the agglutinations, and then the same vial is again warmed to 8 degrees Celsius or maybe 12 degrees Celsius, and then 16 and 20 degrees Celsius, 25 degrees Celsius, or is that the right approach, or we have to actually multiple qubits in that specific temperatures and run the test in that order?
We actually put multiple in different, there are different, like up to at least, we won't be so bothered about 4 degrees. We are more in 20. I cannot tell you right now. We have 3 or 4 levels somewhere near. We look for only if it is something that, the thermal amplitude is higher, will it be significant clinically.
Right. So we have another question. This is any
I hope it's not to do with blood banking. I'm really not a blood bank expert. So that's slightly different.
Dr. Siaram Didal from AIDS, he's asking about a child with splenomegaly, low reticulocyte count, transfusion dependent.
Low reticulocyte count. Yeah, okay.
HPLC is normal and PNH IHA has been ruled out. What is the probable cause?
Could it be a congenital dyserythropoiesis? Has a marrow been done?
Yeah.
That is what I would think of.
Splenomegaly, CDA type 2 can be a possibility. Yeah.
Any case of chronic hemolytic porphyria as a positive for some related gene. Okay. Negative for CDA2. It's must be one of those very rare ones.
Yes, ma'am. And even, ma'am, alpha thalassemia, I do not know the HPLCs out there, but our HPLCs, they do not report alpha thalassemias. This is another one thing that I wanted to ask you, ma'am.
Most of the time, we make a presumptive suggestion. We do molecular testing here. So if you see the typical indices and, MCV and iron studies, sometimes you can have iron deficiency here. Almost 15% of the population has alpha thalassemia in some form. So unless it is HPH or, you may have no other features. So HPH, the retic is also a little raised. You can look for the golf ball inclusion bodies, but otherwise you have to go for molecular testing. So it will be more not finding anything. The HbA2 may be slightly low, may not be low also, what I have seen. And you have microcytosis with raised RBC count. There's no iron deficiency, or you can correct the iron, repeat the HPLC or repeat the CBC, and still there's microcytosis. We would think of associated alpha thalassemia in some form or the other.
Yes, ma'am. So negative CDA. I think, ma'am, use at least 11 cell panel and identify the antibody. Again, transfusion medicine. Okay.
That is, I haven't covered that at all. That we can have a separate lecture for that. My whole idea is I expect that there are a lot of PG students. So I hope they're clear about what is the definition of hemolytic anemia, extravascular hemolysis versus intravascular hemolysis, and about the membrane disorders, what one needs to be aware of, what are the new tests available. And in autoimmune hemolytic anemia, warm, cold, PCH. And in this only the alloimmune is, again, it's a little more detailed. One has to be aware of the RBC antigens, and then about the enzymopathies and about when one should suspect and which are the really serious microangiopathic situations.
Right, ma'am.
Is there any question from the PG students about what I took?
Yes, ma'am. I have got one question.
Yeah, there's a parvovirus infection. Yes, of course. I didn't speak about it. You can have a pure red cell aplasia in chronic hemolytic anemias, especially the inherited ones, because the red cell lifespan, parvovirus infection per se is a self-limiting infection. Within 10 to 12 days, the infection will get cleared unless the person is immunocompromised. So, but if somebody has hemolytic anemia and his lifespan is so short that with parvovirus infection, he will develop very severe, aplastic crisis or pure red cell aplasia. So definitely, yes, I did not mention reticulocytopenia can also be because of a viral infection. Usually parvovirus would lead to very serious kind of appearance, very severe pure red cell aplasia.
Yes, ma'am. Just to point out that you initially mentioned that the hemolytic disorders are the situations where the RBC lifespans are decreased. So the parvovirus infections are usually severe in hemolytic anemia because the RBC lifespan are small.
Yes.
So I guess, ma'am,
are there no questions from the PG students?
Yes, ma'am, there are probably no questions. Ma'am, okay. Your presentations have been very lucid, and actually, while I was, here listening to it, it also cleared a lot of my doubt. Ma'am, I had one more question.
Yes.
Regarding this eosin 5 melimide binding test, it is actually a cheap test. Whenever we have a clinical suspicion of hereditary spherocytosis, we go for EMA binding test. Now, if the EMA binding test is negative, then we ask the patients to do a gene sequencing studies for the RBC membrane defect. But if the EMA binding is positive, then is it okay that we spare the NGS and go directly to the splenectomy? I mean, is that okay?
I think so. We can go back because, and if no, provided you are not in trouble, I mean, you're reasonably sure, your history is fine, you have autosomal dominance. In fact, the earlier guidelines said you don't even have to do anything else. And the one guideline is that you do one screening test. If you have doubt, instead of going for NGS, you can even use 2 screening tests, if that's possible.
Actually, OFT is not done in majority of places, ma'am.
Yeah, and OFT, unless it is standardized, it is difficult.
Yeah.
But if you read the guidelines, they are saying that that's enough.
So, ma'am, we don't have any more questions, and I guess, ma'am, this is the.
We can wind up now, sir.
Yeah. So so again, I want to end by saying that autoimmune hemolytic anemia concept is the same, but for I did not include alloimmune because that's a whole different ballgame altogether. There are many more things that need to be discussed, so we can have someone else can have another discussion on that. Maybe that's why I didn't cover them.
Okay, ma'am. It was really nice listening to you, and
my pleasure. Absolutely.
Let you go have your dinner. Good night, everyone. Thank you so much.
Bye.
Thank you so much.